I don't know. Last week I was really busy. Couldn't every day I had to operate. And who is
I heard that.
yeah.
Sanjeeva told me that you are very, very busy.
Yeah. So who is this you song? There's a message. Did anyone else join apart from the faculty?
Really busy.
I can
Every
hear.
day
I
I
think
had
I
to
told you.
operate. I heard that. Sanjeeva told. No, sorry.
Okay, there's somebody who and
Somebody,
okay, that's fine.
somebody,
No, okay.
someone is trying to connect.
Yeah, that's all right. Yeah.
Good. So I'm gonna go upstairs. I will
Yeah, sure.
stop this video, and in 2 minutes I will see you in a, let's say, more calm environment.
Yeah. Okay. All right.
Pablo, voy.
Hi, Stefan. I can't hear. I think it's muted. You're muted, Stefan. I
Yes.
can hear. Yeah.
No,
Good to see you.
I was on the other link.
Oh, did
Not
you?
other-
That's why.
Yes,
Yeah.
that's why I couldn't speak, but now
Yeah.
it's okay.
Yeah.
Yes.
Very good. Very good.
And thank you for inviting me and for
No, thank you for joining, and I'm hoping to see you as well in Romania
yes
in September.
in September. In September.
Yes. Yes. Yeah. I meant to send out the invitation to our members so that they can tell me their availability as well for the IANA program.
It's better now, but how
Yeah, I
it's
can hear you well, and it's better now.
and yes, you
Yeah.
can be
Yeah.
okay. Thank you. So I will mute myself and I will close the. Hi,
Yeah.
Pablo. I'm here.
Okay.
I'm back.
Okay, very good. Hi,
Imad?
Imad. Yeah, we can't hear you. We cannot hear you, Imad. You are muted.
I mean, good that you did not hear me. I was talking to Florian that he lost all the hair. I could
I
not
never saw
recognize him.
Florian with any hair at all. I don't know whether
I-
last
I-
time.
In one of the presentation, I will present myself with hair, along hair.
How are you guys? Great to see you,
Good.
both of you. And I see the smoking with
No,
the
we
electronic
didn't
smoker.
start yet. We didn't start yet. I can
No,
smoke.
no,
After that, I will.
no, you for sure. I know. After lecture, running outside in the
Hayek.
meeting. How are you, Ramesh? Thanks for
Yeah, very
arranging
good.
all this. Yeah, everything will hopefully
Yeah.
will go smooth. Yeah,
Good to see you all after a long time. Good to see you
yeah.
both. I
It
mean,
has been
at least virtually.
a long break. Yeah.
Yeah, in a long break.
Pablo is there.
Ek.
Pablo,
Hello.
Pablo is there. Ek is frozen.
great to see you. Where is your partner, Pablo? Where
He's
is Pablito?
downstairs.
Pablito
Downstairs.
is.
He and she.
Oh, she. Okay, wonderful. Yeah, very good. And who is with us there? I see. This is Ek. Hi, Ek.
Ek is there, but I cannot.
You are muted.
Ek is sort of frozen.
Yeah,
Now.
I'm quiet here.
Yeah.
Yeah.
It's the middle of the night. I will chime in when I can. Okay.
Oh, okay. Are you still in Boston?
Yeah.
No, I'm currently in San Diego.
Okay. Is the skull-based meeting or he's got cut off?
I think X connection is not very good, so can't hear
He's
properly.
back.
I put some comments in the chat.
Is that you from California?
Is
Okay, very good. Okay, you got your name corrected. That's good.
I just did it. I just did it.
You are
Because
doing
we
it.
send the faculty link for everyone, so I'm just updating it.
Thanks, Pablo.
Oh, it sounds we have an exciting program today with the 2 sessions and discussing. This is nice, some new things to add to the flavor of the IANA.
Yes, yeah.
Yeah.
I saw Vladimir very briefly, but then I think Vladimir disappeared. Maybe till getting ready, I think.
When did we meet last? I think it's almost 3 months, 4 months, because you were at you went to this island, the Friends Island.
Reunion we went at the end of August,
Okay.
Oh,
and
yes, yes. Yeah. Yeah. Hi,
that's the last
Luciano.
time.
Good to see you.
Who's coming
Luciano
on
is a bit
screen?
frozen. Is it? The internet connection seems to be a bit slow for. Is it just me or for everyone?
I checked that also.
Because
Luciano's, I can see him now. Hi, Luciano.
yeah.
You're muted,
You
You are
Luciano.
muted. Microphone.
Can you hear me now?
Yes.
Yes,
Hi.
yeah.
Hi, good morning, everybody.
Good
Good
morning.
to see you. Bye.
Wow.
He got
Vlad.
Hello,
Vladimir.
guys.
Hello.
Oh.
Vladimir.
Hi. How are you
Hi.
doing?
Great to see you. It has been a long
Great to see you
interruption.
too. It's
Yeah.
been a long, long time.
Yeah.
We haven't met anywhere, and
We miss
that
each
is
other. We miss each other.
yeah, good to see you all
Yeah.
again.
Yeah.
Yeah.
You all look well. Heck, you are in the dark.
He's in
Is in
California.
the
Yes.
early morning.
Early morning for them. Yeah,
Yeah.
looks like night.
In
Well,
California.
good to see you guys.
Good to see you.
Good to see you.
James is there. So where is James? So I have to check.
He's in the participants. Let me try to put
Could
him as
you?
panelist.
Yeah. Thanks. Yes, it's on now. Hi, James.
Hey, good morning.
Hi.
Hi, James.
Morning, afternoon.
Hi, James.
Hi, James. You are in the middle of the circles of Willis.
Yes, this is where we live.
Good to see you.
Yeah, good to see you guys. Good to see you.
Yeah. Yeah. And you said that you have to fairly have a busy schedule in the morning, you said. So we will start with you when we start the program.
Okay, thank you for accommodating. Appreciate that.
Right. So, Imad,
Yeah.
Imad is
Is
I
it
think
time
X
to
sent a
start?
message. Yeah, X sent a message that is Wi-Fi is bit unstable. So he's happy for you to introduce and start.
Okay. Well,
Yeah, we
I'm
got
not
4
going to
minutes
make,
actually.
yeah.
Yeah, 2-3
Just
minutes.
few words before we start. I think this webinar won't be successful without giving few words and recognition and appreciation to Pablo. Pablo
Yes.
did a great job, and we have mentioned this one. And thank you, Pablo, for whatever you have done. marvelous. You led the ship very well, and you introduced a lot of activities. You have been always helpful and supportive, and you led the IANA to a next destination. I think we gave you the break so you can still work on the neurosurgery and take care of your son and wife. And we appreciate every step you have done for us.
Thank you.
And the other things, I would like to introduce the new president. Ramesh has been one of the initiating member of this IANA group, and even before that, he has been committed and very think he's the potential to add some activities and move forward to raise the bar of IANA and make it recognized, continue the recognition and make it more recognized and more active. I will cut it short, and one thing we, on behalf of all of us, a few words to say condolences to our friend Kasadi on the loss of his wife, and I think everyone sent messages to that regard. So go ahead, Ramesh, and you proceed with whatever you'd like to say about the IANA new vision, a few words, and then we can start the program.
Yeah, thanks, Imad, and thank you for the introduction, and thank you, Pablo, as well. For me, it's been a great honor to be part of this group. Always, even before, we were friends with the Anatomy Committee and traveled all over the world. So I look forward to that friendship, and at the same time, reaching out to the world to educate on the neuroanatomy, which we all think is the crux of the neurosurgery. And to be a better surgeon, you got to know your anatomy well. That is the whole point of the organization, to update us and also to educate the role of neuroanatomy and then make surgery safer around the world. And we will be having more hands-on courses this year, and friends like Stefan and Lucas, we will be reaching out to other meetings as in-person IANA sessions, and we have more sessions coming up, so we will be part of that. And also in the interim, we will be carrying on with our online activities like webinars, and we look forward to having a very tight collaboration. And I will also let my colleague and great friend Igor to speak few words before we start. We got, I think, another 2 minutes before Igor can. Igor, are you there? I saw him, but it's frozen.
Yes. Hello, Ramesh.
You want to say a few words about our research and fellowship activities?
Yeah, sure, of course. So we have a research fellowship that is linked to IANA. There is a research committee where I have the pleasure to coordinate. We evaluate files, and then each fellow is assigned to a lab for research works in anatomy, can be in vascular, white matter, skull base, with the goal of producing a research paper or a congress presentation or something like that. I would be glad in the near future to present the works that have been done so far. And this have been a very pleasant and fruitful experience so far. The fellows are very happy with their experiences, and all works have been very, very successful. For those that are in underprivileged areas, they should not hesitate to state in their applications that they will need some support for funding for travel and accommodation expenses. So the labs can study their demands, and also they can apply for support from IANA. Maybe Professor Cannon can also say a few words about that regarding the special funding from this research fellowship that was offered by Professor Cannon a couple of years ago.
Well, nothing to add. The money is there. Nobody is using it. So we just want to have applicants. And meantime, I think we have already one finished his fellowship from Argentina, thanks to Dr. Matias, who took him for 3 months, white matter and vascular. And the next will be going to Dr. Abuzur, I think, shortly to spend 3 months with him. And there is one, I think, Pablo, you have suggested somebody who is a potential, I don't know where he's going, coming to you or to.
He will probably come to Alicante, Leonard, from
Wonderful.
Malawi.
Okay, wonderful.
And there is a one finished fellowship from England, 6 months in France. Already finished.
Okay.
Excellent. Thanks, Igor. I think with that introduction, I just want to welcome those who have joined late, like my great friend Moody and Prof. Landiro and Prof. Schroeder, Henry Schroeder. So we were all
Hello.
good. Thanks for all coming, and we'll start the session. I'll hand back to Prof. Imad Kanan. So for the first session, and essentially it's about 15 minutes talk, and then we have two discussants to discuss the various nuances of these cases as well. Then I'll leave it to Prof. Imad Kanan to start the first session.
So I'll just move in with the program. Apology came from Eckhart. He could not join because of the poor connection. The first presentation will be given by Professor James Liu. Professor Liu is a known leader in the skull base and minimal invasive skull base surgery and vascular, has a vast career behind him, and he is going to talk about internal jugular vein compression syndrome at the craniocervical junction.
Great.
James?
Thank you. Can you guys see my screen?
Yes.
Yes.
Okay, let me just enlarge it here. Okay, well, thank you, Imad, and thank you, friends. It's a great honor to be here and be part of IANA. To kick off the craniocervical junction area of the anatomy, I want to talk about an interesting syndrome that I've been treating in the more recent years. Jugular venous compression syndrome, often seen at the craniocervical junction, namely at the level of C1, and often associated with the styloid process. And these veins can get compressed in this area, and they can cause a real clinical neurological syndrome, and it's treatable. This is often associated and sometimes confused with Eagle syndrome, which I believe is a completely different clinical phenomenon. But they're affiliated because they're associated with a styloid process. And often the vascular variant is often described by patients as vascular Eagle syndrome. I don't think that is a good correct term, but it's easy to use. But the association is it's with an enlarged styloid. In the literature, it's been often described as a styloidogenic jugular venous compression syndrome. And the commonality is that the internal jugular vein that you see here is severely compressed, and it's usually situated between the styloid process and the C1 transverse sinus process. And these create symptoms of similar to intracranial venous hypertension due to the jugular vein compression. Anatomically, we talked about anatomically where it is. It's right at the craniocervical junction, right between the styloid and C1. And the styloid process can be elongated, as you see in Eagle syndrome, but sometimes it may not be elongated. You may have a normal appearing styloid, but the vein, unfortunately, is stuck in between this area, causing these venous outflow obstruction type syndromes. So anteriorly, you have the styloid compressing. Posteriorly, you have C1. And then laterally, you can have a branch of the occipital artery that you see here. And then sometimes the posterior belly of the digastric muscle, which is situated laterally, can also be an area of compression. The carotid artery is situated medially, and on occasions, you may have a tortuous ICA that can also cause compression from either the anterior or medial side. So anatomical relationships is important. In terms of clinical presentation, these symptoms often mimic those that you see with idiopathic intracranial hypertension, or IIH. Headaches and head pressure is the most common. Often these patients will talk about brain fog, or they'll describe brain fog. And you may ask, well, what is that? Is that a real symptom? And I will tell you from learning, I learn a lot from these patients and just listening to them. And I take a very detailed history, writing down and asking them to define what exactly do you mean by brain fog. And most of them will tell you that they have some memory difficulties, some issues remembering things. They have some slowness or impairment of their processing, and some form of cognitive dysfunction. Oftentimes, they'll say that they're able to perform certain daily living tasks that they're not able to perform anymore. Visual disturbances is also a frequent complaint. They'll often describe blurred vision, or sometimes they'll describe it as visual snow, which they'll describe as having some pixelated areas in their field of view, kind of like low resolution graphics, if you will. Oftentimes, the formal neuro-ophthalmological testing may be negative without any evidence of papilledema that you would typically see in a pseudotumor patient. They can have exacerbation of their symptoms with neck movements or position change. Pulsatile tenosis is not a consistent finding, but sometimes you may see it. And of course, dizziness and fatigue are also common symptoms. What's important to see is on a venogram or angiogram, you can often see engorgement of the collateral venous drainage, as you see here. And this is due to chronic venous outflow obstruction of the internal jugular veins. So often you'll see a dilated paravertebral venous plexus. And what's interesting is that these patients may not have papilledema, elevated opening pressure with a lumbar puncture. And when we measure pressure gradients, normally for, say, venous sinus stenosis in the transverse sinus, you generally want to see a venous delta gradient of at least 3 millimeters of mercury. But these pressure gradients across the stenotic junction sometimes may not be 3 or greater. And that has to do possibly with the collateral venous outflow. So they may not have the same degree of raised ICP as you see with intracranial venous stenosis because of these collateral venous pathways. Other presentations of compensatory collateral venous drainage. Again, the common one is this paravertebral venous plexus engorgement, but sometimes you can see a dilated occipital sinus. So it's important to look for these clues when you're looking at your imaging. The differential diagnosis can include classic IIH, venous sinus stenosis, or other types of Eagle syndrome variants, venous thrombosis that can result in venous outflow obstruction, and sometimes craniocervical instability that can affect the venous compression. But it's important to distinguish the vascular jugular venous compression from classic Eagle syndrome, which is more characterized by throat pain, ear and neck pain, and dysphagia and globus sensation when they're swallowing. So this is Dr. Eagle, who described the classic Eagle syndrome associated with an elongated or enlarged calcified styloid process or calcified stylohyoid ligament that would cause more of the symptoms of throat pain, difficulty swallowing, and sometimes facial pain. How do you distinguish the two? Again, the symptomatology is different. Usually, Eagle syndrome follows a history of a tonsillectomy, whereas the vascular compression syndrome is usually without. But again, the symptoms of vascular jugular venous compression is more consistent with those of IIH and sometimes can be associated with head and neck movements. So neuroimaging is important. I think the neuroimaging that shows severe venous compression at the C1 joint that correlates with the clinical symptomatology is often diagnostic. It is a clinical diagnosis supported by radiological findings, and oftentimes you may see an elongated styloid process next to C1 compressing or narrowing the vein that you see here. And I always compare it to the opposite side. And you could see on the right side here, you see a more generous physiological looking vein as opposed to the left pathologic side that you see here. You can see it on MRV as well, but I do prefer CTA, CTV. You see the vascular with the bony anatomy, and you can also use this to make 3D reconstructive images that I frequently use for preoperative planning and also decision making. Catheter angiography is useful, I believe. It helps you identify the venous outflow obstruction. You can identify collateral venous drainage, but also we often will use it to measure the venous pressures. And in terms of laterality, the right side is reported to be more common than the left, close to 80-20 ratio. We perform angiography in our series of patients with catheter venography to confirm the stenosis at the C1 level. Here, the pathological side is on the left side, and you could see here there's a very narrow jugular vein here that you see at the level of C1, and it's associated with asymmetry of the paravertebral venous plexus. You can see on the left side, it is more engorged. And so we'll measure the pressure at various points within the venous outflow system and at the site of the stenotic junction. And we look for pressure gradients, usually at least 3 millimeters of mercury or above. But if it's not 3, sometimes we'll see a pressure gradient of 2. And I think that's acceptable in these extracranial cases in the context of the clinical syndrome. So here's a 3D reconstruction after the angiogram. You could see what we're seeing here is this is the styloid process. And then the brighter signals, the internal carotid, and then the more gray structure is the compressed internal jugular vein. You could see it's significantly narrowed, almost nearly occluded. And here the pressure gradient is 2. It's not quite 3, but I believe this is very real. And the patient did very well after jugular venous decompression. It's not always bony compression from the styloid, but it can also be a tortuous ICA. This is a patient I treated last week that had this. If you look on this 3D, it's a very S-shaped tortuous carotid artery here. This is the vertebral at C1, so you could see the compression. The vein is not in view because this is an MRA reconstruction, but imagine the vein being right here in the middle, and the C1 bony transverse process is right here at the level of the vertebral artery. And look how the artery pushes the right here, the artery pushes the vein, and it's severely narrowed up against the C1. And in this case, we removed all styloid process and C1 to get the decompression. And I believe that the styloid process was holding the carotid artery in that fixed position as well. So study your CTA, CTV in great detail to understand where the level of compression is. So in terms of treatment strategies, conservative management can include acetazolamide and analgesics. From the surgery standpoint, you have to identify the elements of compression And I don't believe styloidectomy is adequate enough, although some people propose only a pure styloidectomy as the form of treatment. But you really need to remove the styloid, drill down the C1 transverse process, sometimes even remove the posterior belly of the digastric muscle, which we have done in a few cases. And lastly, an internal jugular vein fasciotomy. There's very restrictive connective tissue surrounding the vein, and if you take the time to spread the tissue, lyse the connective tissue, it allows the vein to really re-expand to its maximal diameter. People have described endovascular options with jugular vein stenting. However, this is controversial and it doesn't always result in a good result because there's bony structural compression and the stent may not dilate the vein enough, and you can also risk venous thrombosis resulting in failure. That area is also an area of high mobility, so the stents typically may not work, and it's not as good as a surgical decompression. In terms of exposure, the classical exposure is a transcervical exposure. This is an illustration from Yang et al. Recently published, but this shows you that the view that you get from a pure transcervical exposure, which is the most commonly used approach. Of course, there can be risk of complications, vascular injury to either vein or artery, especially vertebral artery when you're drilling off the transverse process of C1. You have to watch out for cranial nerve 7 as this exits the stylomastoid foramen, neck hematoma, dysphagia, and dysphonia. And so this is the view you get from a pure transcervical exposure. It's a looking up trajectory. You're viewing the skull base from below, and it gets deeper into a darker hole high above when you're trying to reach the styloid process at its base. So in my opinion, your view is more limited. Your working angles are more limited to this looking up view, and you can increase the risk of facial nerve injury when you're biting off the styloid as you get closer to the skull base. And also, your drilling of the C1 is in a strange oblique angle, and you might be at risk of cranial nerve 11 injury or vertebral artery injury. My preferred approach is the approach that I use for jugular foramen tumors. I call it the extended infralabyrinthine anterolateral approach. It's an extension of the late Professor Bernard Georges' approach, the anterolateral, except we add a mini mastoidectomy. Just taking off the mastoid tip is simply enough just to know the course of the fallopian canal and facial nerve, and we can mobilize the digastric forward, mobilize the sternomastoid posteriorly, and you get this great view because oftentimes C1 is very close to the mastoid tip, and the mastoid tip can obstruct your line of sight and your exposure. So it really gives you an increased working angle and surgical freedom so you can perform safer and more adequate removal of the styloid and C1 to achieve maximal jugular vein decompression. So the incision is slightly more extended. It looks like a C-shaped incision and continues with your transcervical incision in front of the sternocleidomastoid muscle. We're simply adding the mastoid tip removal. We don't drill off all of this area. This is a more exaggerated view if you're doing a complex glomus jugulare tumor. But this is the area of interest that we want to expose at this level of the C1 transverse process. So let's take a look at some case examples. This is a very detailed history, but she had this is a 36-year-old female with chronic headaches and brain fog and left neck pain. You could see she's got a huge styloid and severe compression of the jugular vein that you see here. She really was not able to perform her daily tasks. And so you could see on this video, the vein is severely compressed, almost nearly occluded, with a huge styloid process. The venogram shows a pressure gradient of 2 with a very narrow jugular vein. And I will often use these 3D reconstructive images to get an idea of the anatomy for surgical planning. You can see the transcervical approach is more in this trajectory, but the infralabyrinthine approach trajectory is more of this type of view. And intraoperatively, this is what we see. This is a left-sided approach. Here's the styloid process exposed. The stylohyoid muscle is typically attached to it and is situated just above the posterior belly of the digastric. So we'll go ahead and remove the styloid. This is the facial artery, which we're preserving, pretty large facial artery. And then after we remove the styloid, I then turn my attention to C1. C1, you have to remove the soft tissue in the capsule to get down to the bone. I use blunt dissection so I don't cause thermal injury to any of the neurovascular structures, and we use a 2-diamond and then downsize to a 1-diamond. And the most critical part here is having a good assistant to protect the jugular vein and to protect the 11th nerve as we're drilling. And once I get close to the vertebral canal, which you can typically see the cortical bone where the vertebral canal will be, we stop. But it's important to really get the edges of the C1 so that you create room for the vein to re-expand into. So you see here the vein is now back into place, and the ICG we will do to confirm that the anterograde flow is intact. So you get a 360 decompression of the internal jugular vein, and then I reconstruct the mastoid. I seal off the antrum with a bone wax plate, and then fill the mastoid with hydroset cement, so that you basically, in a sense, you were not really there if you look on the 3D recon. And look at the post-op reconstruction. You could see the jugular vein has significantly increased in diameter. And you could see here on the 3D, the jugular vein has re-expanded quite a bit. But more importantly, the symptoms. Remarkably, in the hospital bed, she subjectively told me she had immediate improvement in her brain fog. She was able to remember in great detail all the members of the surgical team she met in the holding area. Her headaches and vision improved, and she went home on post-op day 1. So the hospital stay is quite short. Here's another case example.
Sorry,
okay,
Jim, 2 minutes.
I'm just going to go conclude here since we're running out of time, but most of these cases are very similar. But I just want to point out a recent paper that actually did a very nice study. This is 27 patients. They looked at quality of life and symptom severity scores and radiographic venous improvement. And all of those 3 measures improved with quality of life by doing the fasciotomy and so forth. And when they did quality of life, 11 of 16 measures that you see here, memory, ability to perform daily activity, all of these things that were very negatively impacting the patient's life significantly improved. So in conclusion, I think this is a real phenomenon. I think it's a treatable disease. And if you know the anatomy, it's a very simple operation to perform. And I think you can help a lot of patients with this condition. I want to thank my team that helps me with doing these operations, and I thank you for your attention.
Thank you very much, Jim. It's a wonderful presentation and a nice a disease entity that not all of us were aware of it, actually. I never treated one like this. It's good you draw the attention of this disease entity. Thank you. I think we'll keep the question later. We have a discussion at the end of the session. I'll invite our next speaker, Pablo. He's going to talk about the different approaches to the CP angle and variants from anatomical point of view. Pablo is trained in Barcelona, and he leading the skull base section in his hospital, University Hospital in Alicante. Pablo, are you ready?
I am ready. Can you hear me, Matt?
Yes.
I'll try to be very brief. And this is a very basic talk, but I think it's very relevant for young surgeons like myself. So it's going to be mainly on how the anatomy can help us to optimize our approach and to reach lesions in the CPA. First, starting with some data. Full intracranial volume, we have 1.5 liters. which are mainly supratentorial. Infratentorially, we have only 350 milliliters, but importantly, we have very relevant structures. And I will try to go through all these different anatomical layers in the posterior fossa regarding the CPA approaches and how we can plan our surgeries based on this knowledge. So this is the posterolateral, let's say, trajectory to the CPA from the lateral suboccipital, or also called retrosigmoid approach. And this is the view we should have when we approach and release the CSF and open the cisterns. But if we want to reach the most medial or anterior aspect of our CPA regarding the edge of the petroclival junction, this should be the edge of our approach, we should focus a little bit deeper into our microscope. Why is it called angle? Because it's a real angle. This star is the superior view of the relative location of the CPA, but the CPA indeed is marked by this fissure, the cerebellopontine fissure. So here we have important structures like the cranial nerves, entry and exit root areas, and we have also important vascular structures regarding to them. This is a very classic and easy to remember classification of the different compartments of the CPA, where we have the posteriorly located nerves, which are the 5th, the 7th and 8th, and the lower cranial nerves, and then the medially or anteriorly located cranial nerves, which are mainly the abducens, 6th, and the hypoglossal nerve. Why it's important to know these structures? Because most of the cases we are gonna deal with in this area are benign diseases. So that's why it's still even more important to do a perfect surgery here. Let's start with the continent, bone and sutures, and this is very important because this is the gate to the CPA, and this area is important to know the petrous segment of the temporal bone, parietal occipital bone, and the clival area, which is the limit, as we said, of our approach, the petroclival region. And thanks to the anatomical knowledge, and in some specific cases, we can even reach petroclival lesions with this very easy and fast retrosigmoid approach. The edges, also dural layers. This is the next layer that we will be uncovering after opening the gate, after removing the bone. And here we will find the dura, and importantly in the posterior fossa, we have the junction of different venous sinuses. And this is the, let's say, superior cover of our posterior fossa with the tentorium. If we remove the dura of the posterior fossa all together with the falcotentorial junction of the falx, from the anterior perspective, we can see this kind of Romanic hedge shape, in which we can see how, as we move anteriorly, our gate is going superiorly and superiorly. So you can see how the midline is much more higher than the most lateral aspect. And this is relevant and measuring the tentorial angle in those cases in which we want to combine retrosigmoid exposure to the CPA with a supracerebellar infratentorial corridor. It's important to be aware of this angle, that it's rising higher in the medial or anterior aspect. Important also is to know that in the posterior fossa, this falcotentorial junction, the 10th, and the dura of the petrous bone is in very close contact with the important sinuses, venous sinuses, superior and inferior petrosal sinuses, which are coming from the cavernous sinus and joining all together superior petrosal sinus into the transverse sigmoid sinus junction, and the inferior petrosal sinus running directly to the jugular foramen. Also, we can identify and project our cerebellopontine angle anatomy into this area where we have the trigeminal nerve, 7 and 8 cranial nerves in the internal auditory canal, and the jugular foramen with the lower cranial nerves. From a superior perspective, we can see again how the sinus rectus, which is located in the falcotentorial junction, is running quite up. So from the vein of Galen running down to the torcula, measuring again the angle is very important when we are planning to approach, for example, a midbrain lesion. Let's have a look at this case. We can see this is clearly a meningioma, and starting with the study of the anatomy is the most important thing. Where is this tumor growing in? Because this is probably a point in which most of the feeding arteries will be feeding the tumor, and this is a point in which we want to reach very early into the surgery so as to devascularize the tumor. So you can see how this meningioma is growing in the falcotentorial junction quite close to the petrous apex. So analyzing where the tumor is growing is very relevant. This is the right-sided exposure. So this is the tentorium, and this is the petrous bone dura. So the tumor is growing here. So this is the area we want to attack, first of all, in order to devascularize. Why it's important to devascularize? Let's have a look. First of all, how I prepare these cases. This is the position in which I like to work. It's not the most comfortable for the surgeon, I must recognize, but it's very comfortable for the patient, for the anesthesiologist, and for some homeostatic and physiologic aspects, as I will try to prove you. So this is the lateral position, and I like to turn the head a little bit towards me. You can see I'm pushing the ipsilateral shoulder inferiorly and anteriorly, so as my maneuvers are a little bit more comfortable. This is a curvilinear incision I do behind the ear, and then we start identifying our craniometric points. So this is the line in between the posterior root of zygoma and the inion, and also a perpendicular line coming from the digastric groove. This is the point where we should somehow localize the transverse sigmoid sinus junction. So this is the area where we want to place our bar hole, which is, let's say, 1 centimeter posterior to the junction at the level of the so-called asterion, which is the junction of the occipitomastoid, parietomastoid, and lambdoid sutures. This is not generally the junction of the sinuses, so that's why it's much, much safer to do the bar hole in this area, because the junction is going to be a little bit more anterior. You can see it here in this 3D reconstruction. This is the point where we expect to find the junction, and this is the asterion. And having a look from inside, you can see how these craniometric points are very, very trustable in most of these cases. Bar hole, as I said, located into the asterion, and then we expand our craniotomy towards the posterior edge of the sigmoid sinus and the inferior limit of the transverse. Bar hole, craniotomy, these are the 2 traces I do. First, posterior-inferiorly, secondly, inferiorly, just posterior to the emissary vein, or even through the emissary vein, because this emissary vein usually is going obliquely towards the sigmoid sinus, so it's safe to work like this. In most of the cases, especially in cases in which we are dealing with big tumors, it's very important to try to drill as much as possible so as to see a little bit the posterior part of the sigmoid sinus. So skin incision, this is what we start doing. In those cases in which we cannot see the sutures, just drilling a little bit with the drill is very useful. Then we can check that this is the inferior part of the transverse sinus. Then we go with the craniotome and expand our craniotomy as anterior as we can, sealing the bone wax air cells. Then, next step, opening the dura and releasing CSF. Many ways to open the dura. I like the opening towards the sinus, just posterior and inferior to the sinus, and directly going to the cerebellomedullary system. This is a moment in which I don't not only release CSF, but also release my nerves, because then the posterior fossa is quite released. And thanks to this positioning of the patient, which is rotated a little bit towards me, after releasing CSF, the cerebellum is going to fall down a little bit thanks to the gravity. So next step, it's surgical planning. We want to attack the area where the tumor is being fed. So in these cases, like meningioma, if we attack directly this, even without touching the debulking too much the tumor, we can convert a very, very bleedy tumor in a tumor like this, dark like this. Let me prove it to you. This is the meningioma, which was located in the petrotentorial junction. This is the devascularization, petrous, bone, dura, and tentorium, so devascularizing as much as we can. And with this approach, you can see how the cerebellum is falling, now attacking the tent, the feeding, and now the meningioma is almost completely devascularized, and you can see the color of the meningioma. Now it's much, much easier and comfortable to debulk the tumor. This is the last portion. So posterior to this, we have the fifth nerve and the Dandy's vein, which is right there. But thanks to this devascularization, this task is much easier. Drilling a little bit the suprameatal tubercle so as to get the last portion of the tumor, and even a small part of the tumor just behind the Dandy's vein. So this approach is very, very fast and is very comfortable to remove a tumor like this. So arterial system and the so-called posterior fossa compartments, you are aware about it, superior, middle, and inferior. Starting with the superior, we have the trigeminal nerve, and also, importantly, the superior cerebellar artery, which are located in the superior part and anterior part of the so-called cerebropontine cistern. So this is the cistern we want to enter, especially when we have a conflict, neurovascular conflict, like in this case, classic trigeminal neuralgia. I could see a vessel here compressing the nerve, but once I open the dura and release CSF, I was exploring the trigeminal nerve. Superior cerebral artery was far away, and I couldn't see any vessel. So important to have some good tools like the 30 degrees endoscope, with which we can see behind this prominent suprameatal tubercle where we have this hidden vein, pontine vein running up, which is compressing the trigeminal nerve. So drilling the suprameatal tubercle and finally creating a space so as to decompress that. Introducing the Teflon, and this was a very, very uncomfortable venous compression. So let's go to the middle compartment, 7 and 8 nerves and ICA. This ICA is a direct branch of the basilar trunk, mid portion of the basilar trunk. You can see how the trigeminal nerve and the 7 and 8 nerves are closely related in the same, let's say, sagittal plane, but as they are moving anteriorly, trigeminal nerve is running quite straightforward, while the 7 and 8 nerves are running more laterally or posteriorly. So classic neurovascular compression syndrome, hemifascial spasm. You can see how uncomfortable is this, and we can see a pica superior loop, which is compressing the 7th nerve, especially the root exit zone, which is the area where we have usually this compression. So lower cranial nerves, this is the flocculus infrafloccular, so that's why we want to decompress and release the arachnoid on the flocculus. So these are the cisterns and the membranes, and once we have opened that, we can see how the 7th nerve and the superior loop of this pica are in close contact. So separating the pica and just pushing this Teflon, fixing it with some tissue cold, it was quite enough. Checking with the endoscope again, you can see how we push this pica. You can see the 6th nerve, which is quite common to be traversed by this ICA in this case. And this is the postal. This is a hidden area, as you saw. It's somehow difficult to see behind the flocculus with the microscope. This is a very small dermoid, but very uncomfortable, producing instability and growing year by year. So I want to show you how with the microscope, we can release and remove most of it. And once we are quite happy, we checked with a 45 degrees endoscope, and we saw this remnant, which was invisible with the microscope. So using the endoscope is very, very useful in some cases. It's important to know how we can create problems. And in this case, I was drilling the internal acoustic meatus. I like to show this video because it was very illustrative, that we don't have to place a cotonoid. And we learn from complications. So what happened is that this cotonoid crashed with my drill, and that was the beginning of the surgery. So that was very uncomfortable. It was a small ICA branch in the petrosal surface of the cerebellum. After controlling it, we were able to remove the schwannoma, but the post-op course was quite uncomfortable. You can see how this ICA infarct is causing this issue, but a few months after, at least the patient was quite okay. And petroclival tumors like this meningioma, it's important to know that in some cases, very easy, simple, fast approach, and I learned this from Vladimir Venesh, is probably the best way so as to deal with tumors like this. And important in this kind of cases is to check again where is the tumor growing from. Superior part of the petroclival junction, we can see it in this T2, and this is the area we want to attack first of all. So releasing CSF, opening the membranes, and unfortunately we are finding the trigeminal nerve and the 7 and 8 nerve complexes just posterior to the tumor. So this is the trigeminal nerve, and then this vein, and the tumor is behind. But taking care and releasing CSF, opening the membranes, the arachnoid membranes, and just attacking the area of vascularization is the most easiest way to deal with a tumor like this, working above the trigeminal nerve and just below, devascularizing and decompressing the tumor. And finally, we can have a good space so as to deal with a tumor like this. This is the basilar trunk, posterior located, we have the tumor. So it's important to debulk as much as we can before starting the resection maneuvers. And with this fast and safe approach, we can finally remove the tumor. This is trigeminal nerve, and this is 7 and 8 nerve complex. So finally, inferior complex, same approach, but in some cases we need to expand our craniotomy towards the foramen magnum and even removing the C1 arc, like in a fibrous solitary tumor like this, which was located on the vertebral artery, just expanding the craniotomy towards the foramen magnum. As you can see, this is the retrosigmoid and this is the C1 removal. It's very, very safe to deal with a tumor which is, as you can see, growing in the wall of the vertebral artery. So finally, just to conclude, this is a very abstract conclusion, but it's summarizing some of my thoughts. Neurosurgery is all about anesthesia, hemostasis, anatomy, having the patient, anesthesiologist, and yourself in a comfortable positioning, and finally, manual skills. But this is probably the less important thing because even a monkey can learn. So let's pay much more attention to anatomy and anesthesiology issues. Just to conclude, this is something I was working, and I'm very happy that Ramesh is taking the responsibility of directing the academy and this group of friends. This is one of the projects I was working the previous 2 years, and it couldn't see the light because some logistical issues, but I want to show you that we are very close to have our own website. It's IANA.online. This is a surprise. Nobody knew that, but I just wanted to share with you that I'm trying to work on this and to summarize all our past webinars, future events, and even I'm trying to prepare a video library with all our talks that will be accessible for everyone in this website. I expect to have it ready in the next couple of weeks, so I will really update you on this. Thank you.
Thank you, Pablo. Very illustrated cases and very nice approach. You cover it all. We'll move to the last speaker of this session, Professor Stefan Florian from Cluj, Romania. He is heading the department and he has contributed to vascular pediatric many aspects, skull base, just name it. And today he has selected a topic that he himself deal with it. Is there a place for surgery in the posterior circulation aneurysm? Stefan?
Thank you very much. Can you hear me? Can you see the presentation? Okay,
Yes.
Thank you very much for inviting me. I'm very glad to be along with my friends here. So I chose this topic because it's less and less used and discussed among the neurosurgeon. And the question is there a room for surgery in nowadays when endovascular treatment is the main tool for treating this kind of pathology? As usual, I have no conflict of interest. I'm only in conflict with surgeons who avoid to operate. My single interest to promote vascular microneurosurgery. So what about epidemiological data? We know from the literature that the posterior circulation aneurysm account approximately 5 to 15% of all intracranial aneurysms. So their incidence, it's not so high. The experience with them, it's quite difficult to achieve. And nowadays it's more difficult because most of the cases are sent to the endovascular treatment. But based on the literature, we know that the mean age is around 55 years. As usual, the female predominance, especially in posterior fossa, up to 70, almost 70%. And the location, it's similarly distributed between upper, so the basilar and the posterior cerebral arteries and the superior cerebellar arteries, and lower third, meaning that the vertebral arteries and the pica. But the rarest location, it's in the middle third, less than 10%. Nowadays, only 11 to 15% of the cases, based on the literature we have, are surgically occluded. So surgery in this kind of pathology has a lot of challenges, and most of the challenges are coming from anatomical point of view. Pablo already presented some very nice anatomical key points in this region. And we know from the study of anatomy that there is a deep and narrow surgical corridors, the proximity of critical brainstem structures, dense concentrations of perforating arteries, and sometimes the aneurysm encasing the neurovascular structures. Very important, and this is related to the previous speaker, the physiology, and related to the anesthesiology, because brainstem and cranial nerve have a lower tolerance to ischemia, to the temporary clipping. Another aspect, it's related to the patient positioning. I rather prefer the semi-sitting position. We are very familiar with this, and we will discuss a little bit later. And CSF dynamics, because once you open the cisterns, especially in sitting position, you have a large amount of CSF evacuated from the posterior fossa, and you create the conditions for the pneumoencephalopathy. So also technical, because of the location of aneurysm, there are angles, different angles, and the application of the clip, it's not always very appropriate. So again, temporary clipping can create problems in the brainstem, and sometimes you should work in between the nerves and arteries, and you displace these structures that can present some neurological alteration after the operation. So a lot of problems, not to speak about the bypass complexity in this, especially in giant and large aneurysms. So why there are some indication only in very selected cases nowadays? In my previous 20 years, I operated much more frequently the posterior circulation aneurysm than in nowadays, because the patient doesn't even reach our department. They are sent by the neurologist or the emergency directly to the endovascular. So only few cases are reaching our hospital, our department. But still, based on the studies in centers with large volumes, there are some advantages for surgery. So it's like in the anterior circulation aneurysm, there is a superior and durable occlusion. There are some complex and morphologically aneurysm unfavorable for coiling or for stenting, flow diversion, especially in ruptured aneurysm, and this is particularly relevant in ruptured pica. There can be large hematoma, and you should decompress the posterior fossa in order to save the patient's life. Sometimes, and more frequently, we discover cases in which the endovascular therapy failed, and we should act on these cases, which are usually very difficult to solve. And do not forget that, and I spent most of my career with limited settings. That's why I was forced to operate. We didn't have in our region an endovascular center. Only in the last 2 or 3 years, we opened a private one, and another one, it's 100 kilometers far from Cluj. And that's why we are somehow forced to operate. Still, we are operating most of the ruptured aneurysms. So This is available in many other countries. The cost of the, at least in Romania, the cost of the flow diverter, it's around 10,000 euros. I don't know what is the real cost, but this is the situation in Romania, and not everyone is able to reach this cost. And also in the coiling, it's quite expensive even for us. So the surgery remains a life-saving measure for ruptured aneurysm, especially. So what are the approaches recommended for upper third? Most of the cases are approached through a pterional cranial orbiter approaches. This is from the literature. Far lateral and retrocondylar approach for middle third, and subtemporal transtentorial also for upper third, and retrosigmoid approach for ICA and PICA cases. This is a retrospective study we performed 5 years ago, and among more than 1,200 operated aneurysms, we had, I think, less than 5% of the posterior circulation aneurysm. Based on my experience, I don't need too large openings in order to reach. Once you have a good brain relaxation, you open the cisterns, you can navigate in between the spaces, and you can reach almost everywhere without removing too much from the skull base. Most of the basilar tip and superior basilar tip and posterior cerebral artery I can reach with pterional approach, half and half when the basilar tip is below the posterior clinoid, lateral suboccipital and retrosigmoid, that as it was presented by our friend Pablo, I think it's enough for most of the cases of PICA and ICA, and also vertebro-basilar junction and median suboccipital, classical suboccipital approach for vertebral artery. So I consider that positioning it's very important in surgery of any kind of aneurysm, but especially in the posterior fossa. The position that was presented by Pablo, it's very nice. We are very comfortable, and we have a large experience with sitting position, and that's why maybe I rather prefer this positioning. Semi-sitting position we introduced in 1977 in our department, and since then most of the posterior fossa lesions are operated in this position. When there is an acute hydrocephalus, certainly we decompress, introducing an external ventricular drainage. We are opening the basal cistern, and all the spaces are quite large, and removing also the clot, we gain more space. So when to operate, based on our experience, it's maybe better not to operate immediately after admission during the night. I rather prefer to offer to the patient and to the team some hours, and we are operating in the next morning when the most experienced team, it's and this is meaning that not only the surgeon but also the most experienced anesthesiologist is in place, and we have all the condition, and also the patient is stabilized. This is mostly available for posterior circulation aneurysm, and with few exceptions, when there is a very large life-threatening cerebellar hematoma. So I only want to present some few, apologize. This is a case with an bacterial approach. I will move faster because I don't have too much time. So this is a small ruptured aneurysm on M1. So after we clip this aneurysm that was ruptured, we go farther. Apologize. We go farther to dissect in between the carotid. In between, apologize, in between the carotid and optic nerve, in optical carotid triangle, and we identify the aneurysm located at the vertebral tip, and we dissecting and we identify the neck of the aneurysm, and we place the permanent clip. So this is another case with an M1 bifurcation aneurysm. In the anterior circulation, I'm not afraid to place a temporary clip, especially when there are some complex aneurysm bilobed or very tightly attached to vessels around. We coagulate in order to reshape the aneurysm, and after we dissect and identified all the aneurysm, we place the definitive clip, and then
2 minutes, Stefan.
Okay, I will go faster, and this I will only present. This is a median suboccipital approach in which we identified the aneurysm that was ruptured on the vertebral artery. The surgery was quite easy, and this is a very interesting case in which the patient was presented with a trigeminal neuralgia. We identified this small pica aneurysm that was compressing the brainstem just at the origin of the facial trigeminal nerve. We clipped them firstly, and then we moved toward to decompress. Other cases with the thrombosed, a ruptured one, and a large one. I will not insist on them. There are a lot of complication, and based on this study published quite recently, last December, we see, comparing with the anterior circulation, there are poor neurological outcome in 37% of the cases, neurological deficit compared with 9.3 in the anterior circulation, up to 34%, and all causes adverse events, and 22.2%. So in conclusion, there are cases in which surgery is superior to endovascular, especially in young adults with a long life expectancy. And the surgery should remain the first choice for ruptured distal pica aneurysm. We should continue the exercise to keep the surgery for posterior circulation aneurysm, especially for those who are easily reachable. So I will end now. This is a poster I presented many times, but I would love to launch now the invitation to participate in our national congress that will be held between 16 to 19 September in Brasov, in the middle of the country. And we should keep the tradition we introduced 3 years ago with a IANA session during our congress. Thank you very much for your attention.
Thank you, Stefan. I think the first session is concluded. Now we are left now with the two invited discussants, distinguished discussant, Professor Henry Schroeder from Greifswald, is known for his minimal invasive technology and endoscopy other than skull base and other neurosurgical activity. We are always jealous of his videos that nobody can compete with him. And I don't know whether Professor Mauricio is there. I
Yeah,
didn't
he
see
is
him.
here. So I can say
Thank
yes.
you,
Dr.
Iman.
Mauricio Giacongelli, he's a skull-based surgeon from Ancona and Marche. Marche is the place, the birthplace, I think, correct me if I'm wrong, of our colleague, God bless his soul, Fred Gentili. And I visit the place, it's a fantastic, and what is Professor Mauricio is doing is fantastic in skull-based surgery. So I leave the arena for you to discuss these papers and your comment. Please, Henry, go ahead, and it's your turn.
Okay, let me start with the first paper from Jim. Nice presentation as usual, and very, very rare, obviously. So the problem is I have never seen these cases because nobody is sending it to us. But what is for me interesting is what you present as the symptoms with brain fog and dizziness and headache, visual problems. It reminds me very much to pineal cysts without ventricular dilation. They also present this, and you know the theory. One of the theories, what is the pathophysiology behind the pineal cyst without ventricular dilation, is that they compress the internal cerebral vein. So you have a kind of venous hypertension in the basal ganglia on the thalamus. It's very interesting. But on the other hand, I think it will only happen if there is certain venous anomalies in the venous outflow. This is what you have shown, the compression while started process and C1, this occurs very slowly. And when you have a very slowly venous compression, then usually collaterals form. So when the circulation would be okay, that means sigmoid sinus, transverse sinus, confluence, and goes to the other side, it should be easily compensated, even if you sacrifice the vein at all. So there must be also a problem on the other side until it becomes symptomatic. Do you agree with this?
Yeah, no, everything you mentioned makes sense. And, oftentimes we have jugular foramen tumors that occlude the jugular vein, and these patients don't have these types of symptoms. So I'm very perplexed why these patients are so symptomatic. But nevertheless, I think it's a real phenomenon. And even though they have compensatory dilated collateral veins, it's still not enough to relieve their pressure symptoms. So I think there's more to be studied, and I think that's why we're doing a lot of venous manometry to try to get more data. We hope to do follow-up angiograms to measure if there's any changes in pressure or if there's any resolution of their collateral venous drainage. But I think it's a real thing, and the more I learn about these patients and speak to them in detail, it's really remarkable that they have very consistent type of symptomatology.
Yeah, it's very interesting. Who is sending the patients to you?
Sort of a variety, sometimes they come from ENT, sometimes typically they're self-referred. They do a lot of internet searching and so forth. Yeah.
Yeah, very interesting.
I have the congratulations, James, for the presentation. I have the same your experience. Sometimes it's not enough to remove the styloid process or part of the sternocleidoid muscle, but essential is to remove the fibrous band around the vein. And this is why, even in my opinion, is the failure of the endovascular treatment. All the cases treated by endovascular almost had a partial resolution. My question is, did you use this technique even for multiple sclerosis or not?
No, I have not used this technique for multiple sclerosis. Can you please elaborate the condition related to multiple sclerosis?
Yeah, it's questionable, but in Europe, some center use this for multiple sclerosis. I never use with multiple sclerosis, but some
some concern.
Jim, I get the same feeling as Henry about the pineal cyst. But unlike in pineal cyst, you listed a long list of possible complications. I would be rather afraid offering such a surgery to patient with, let's say, diffuse symptoms.
No, that's a very valid point. I mean, I think the risk of actually incurring those complications is low, but nevertheless, I always think it's important to, based on the anatomical area that you're working, you have to disclose all the potential disasters that can happen. But it's interesting. These patients, they often get written off. Like they'll see multiple doctors for years and years. They see a neurologist. They don't know what to do. They say send him to a neurosurgeon. He reads the report. There's no pathology, and they see an ophthalmologist, and there's no papilledema, and so they have nowhere to turn, and they often are sort of suffering in silence. And so I think this is a procedure that we can offer them and give them some benefit and improvement of their quality of life.
I have a question. You said you treated some of them conservatively. What the fraction of the surgical aspect to treat these people? How many cases? 20%, 10%, or less than this?
Well, most of these patients have already undergone years and years of conservative treatment. So by the time I see them, I don't put them through a course of conservative management. But on the slide, I only list, the typical conservative management options.
How many cases you have done per year, about roughly?
Well, I just started doing these, and so I've done a total of 5 in my series. And the largest series that you saw there was from Australia, 27 patients, and the next largest series was 14. So so far,
James,
there's not a lot of large
series.
series.
Yeah, those series, were they done by the head and neck surgeons or were they done by because we never see them, and as Henry mentioned,
ENT, per se.
ENT.
Yeah, the series written by ENT usually are just styloidectomies without C1 reduction, and the ones that are multidisciplinary with a neurosurgeon have a C1 drilling. So I think that's the sort of the skill set that is added from a neurosurgeon or skull-based surgeon.
James, just to make my information correct, you have double board. Are you trained in skull-based neurosurgery and ENT surgery, or only skull?
No, I had a joint faculty appointment in both departments, and I just from long-term collaborations, but not formal training in ENT. But I've done a lot of work in temporal bone work and just a lot of neck dissection anatomies, just with years of collaboration.
So we still have question, I think, for the paper, second paper. We want to discuss it.
From Pablo?
Pablo's, yeah.
Where's
Henry,
Pablo?
give him a hard time.
Pablo has shown very nicely, as usual, the anatomy of the CP angle, and I completely agree with him. When I was a resident, it was always a standard big opening, but now we make a tailored approach. We make the superior one, which goes to the trigeminal nerve, or we go to the midbrain. We have the middle one, which goes to the CP angle. We have tumors for vestibular schwannomas, for meningiomas, and then we have the lower one, which most frequently used for hemifacial spasm, or you have some tumors at the jugular tubercle. So I think it should be tailored according to the lesion you have. And then you make a small approach. And what you also mentioned, and I completely agree, of course, is the value of the endoscope in all of these indications. When you have a prominent suprameatal tubercle, you cannot see in trigeminal neuralgia what is the reason for compression. Sometimes you think it SCA, then you take an endoscope like he did, and you find a vein which is at the entrance and the Meckel's cave and is the origin of the problems. It's not always a proximal compression. It's interesting. It can be peripheral, but I have never seen a peripheral problem in hemifacial spasm. Always it is at the proximal brainstem side. It's interesting.
True. Well, but thank you, Henry. Indeed, I learned about the endoscope from you, so I was sure that you completely agree.
Especially epidermoids, ideal, really.
Yeah.
Even if it goes to the to another compartment, Meckel's cave, it goes up over the tent with an endoscope. You can take it when it goes to the other side in front of the brainstem. You can take 45-degree endoscope, curved suction, and you can remove it. Yeah, for epidermoids, it's ideal. I love it.
Well, indeed, the case I showed about the venous compression, it was the, let's say, the extreme case, because the suprametal tubercle was quite prominent and the vein was quite anterior, close to Meckel's cave. But if you analyze properly the T2 volumetric sequence, you can even know that it's a vein, But I just wanted to show it because it's a tool that sometimes we can be lazy and okay, let's drill the suprametal tubercle, but it's just 2 minutes to have a look, make sure where you want to drill and what you need to expose, and that's going to be ideal for the patient. So I think it's a marvelous tool.
Especially I like that you will be very honest and shows this disaster with a cottonoid. And when I was a resident, I saw the same, but more unfortunate because the facial nerve and cochlear nerve were gone. So from that type point, you should never have any cotton, even if it's far away in the field, because of this high rotation, it's like sucking it and then you will damage it. It's very much of value that you show that, and I hope everybody who's watching will put anything out, even if you have double thumb, take it away. Should be nothing inside which can be catched by the drill.
Thank you.
Hi, Matt.
Totally agree.
Yeah, now the last paper, if any questions? To Stefan on aneurysm.
I congratulate with Stefan, and at least in Italy, I'm surprised about how many cases, because in my institute, maybe in the last 5 years, we operated just 2 or 3 cases, because all are treated by the endovascular neuroradiologist. So I agree, because the young people must know this surgery, because the worst case can happen. And I operated the worst cases. But without that experience, then maybe, I don't know, only when I see Charles Drake had, but now. What is your comments on this?
Yes. Apologize. I was muted. So as I mentioned, in the first 20 years of my experience, I operated much more than in the last years. But up to now, I have less than 100 operated cases with posterior fossa. But in the last 3 years, I operated, I think, five cases, and all of them were quite complicated. So it's not frequent, but I feel confident because I have experience with other kind of operation in the posterior fossa, and I have a lot of experience with aneurysm in the anterior circulation. So I know the anatomy, I know how to deal with intraoperative rupture. I'm not afraid, and this is my advice: do not panic. When you see the blood, we are surgeons. We are surgeons, all of them. Operating on the living patient means that sometimes they bleed. So
Fortunately.
Yes. Don't be afraid, don't panic.
I think we have to conclude the session. And
I would like to have a remark.
Yeah,
Matt, please.
Yes, please.
Stefan, I'm glad you have raised the topic, because I'm convinced that a patient with ruptured pica aneurysm in a bad condition can be treated only by surgery. If you remove the blood, you remove the clot from the fourth ventricle, and you give a patient a chance to improve. You can never achieve this with endovascular treatment. So these pica aneurysms are typical surgical cases.
Yes, I agree. I completely agree.
Thank you. Valid point. Okay, we move to Ramesh to move for the next introduction.
Thanks
Ramesh.
very much. Great session, and thanks everyone for the contribution. Start with the next one, and I've got my co-chair, Prof. Sanjeeva as well here. So we start with the first lecture by a good friend Vladimir. Vladimir, you're the first one to respond, and you are the mainstay in our IANA webinars all the time. So I'll invite you to speak on CCJ cranioscervical junction meningiomas.
Okay, thank you, Ramesh and Sanjeeva. Hello, the co-chair. I will talk about my favorite tumors, which are CC junction meningiomas. The definition of the region is the lower third of the clivus and upper edge of C2. Laterally, the tumors are medial to jugular tubercle, and posteriorly, it's anterior edge of the squamous occipital bone in C2. This is the publication of my very good friend Barnard George. What the tumors look like is these tumors which are below the vertebral artery. I'm not quite sure whether they can be really called CC junction, but they fulfill the criteria. This is the approach for these tumors. You want to hit this region. The specimen is from one of the weekends which we spent with Pablo and Troy in Alicante, and we just did this approach. And this is the triangle you see. This is the 11th, 9 tenths, and 12th nerve. These are the real important structures. The most important structure or the most difficult structure is the 12th nerve. And once you find one band, do not believe it's all, because there can be more hypoglossal canals or more strands of this nerve entering the dura. The next important structure or next important part is the anterior spinal cord artery, which is well hidden and which you would find in large tumors extending to the opposite side, and one should think about it. The big vessels are not in danger, but the small ones definitely are. So these are the spinal tumors. Those are not the CC junction tumors. This is the jugular foramen tumor, which doesn't reach the CC junction and doesn't fulfill the criteria. And this is the clival tumor. So these are not the tumors I'm going to talk about. I'm going to talk about real CC junction. This is a very rare. I've seen only one on the posterior rim, and this is definitely a piece of cake. And how we do it in a prone position, either with microscope, but recently I prefer microscope because it gives you much more flexibility and much better angles, especially when looking from down up. Using the chair, having all the comfort and all the ergonomics. So this is the tumor which is typical for this region, and this is the surgery like a battle. First surround the enemy, so 11th helps. You find it dorsally and either move medially or laterally, then you find it in jugular foramen, you are then around the tumor. The next step in this battle is to cut the supply lines. It means going for the origin, then decrease the size of the enemy, which is the tumor decompression. The next step is clean the last pockets of resistance. These are the parts of the tumor in front of the vertebral artery. There is nothing which you can harm. Then this is extremely rare in these tumors, direct involvement of the arachnoid of the brainstem. And the last step is the 12th nerve, which is here. And then, of course, like in any battle, you have to reconstruct the territory. The tumor itself is ample space. You do not need any too sophisticated approach. It's everything either lateral or far lateral, whatever you would like to call it. And once you remove the soft part of the tumor, here is the calcification. You want to remove it to get Simpson 2 and see how much space the tumor itself gives to you. You do not need to see the brainstem. You do not need to move anything, and you easily resect the whole calcification by drilling. And you can achieve nice Simpson 2 resections. Simpson 1 is not over here. Even if the brainstem is posterior to the tumor, there is always ample space or enough space to there. You see spinal cord, and you still get the space to resect the tumor from this lateral or far lateral approach. So this is at the beginning, just exposing the tumor. And here after the resection, the tumor, you see that the tumor is resected, and this is that the tumor is completely resected without any neurological deficit. We are always talking about resecting the condyle, like in this case, which is not necessary because all the work you can do either from above or from below the condyle. So the resection of the condyle is not really necessary, just to the vertical line. These are the angles which give you, and the angle of approach is given by the slope of the muscles during your approach. It's not given by the drilling. The approach and the angle is really given by the slope of the muscles. And if the muscles are well retracted laterally, then you reach the opposite side vertebral artery quite easily without even touching the spinal cord, because the tumor gives all the space you need, and the same is from above and below. So in the past 10 years, I've had 32 surgeries in 31 patients. One underwent 2 surgeries. There was no mortality. There were partial or temporary cranial nerve deficits, 9 through 12. One even called for tracheo and PEC, but it was temporary for 2 months only. And all these deficits improved. And there were, in 2 patients, there was temporary mild hemiparesis lasting 1 or 3 days. And of course, CSF leak in this region happens almost in all series. What about the remnants? This is one remnant we had to leave below after this removal of this tumor. This is the part of the tumor which is in between the layers of dura. It's stable for 6 years. We never needed to start any other treatment. Another grade 4 Simpson 4 patient, really ugly tumor, irregular with very tight attachments to the brainstem. So this small piece I have left behind, and it's stable for 8 years. So no upfront radiosurgery, just following. So these are the only 2 cases of Simpson 4. These are some bizarre cases: bilateral meningioma in the CC junction. And this is the combination of meningioma and schwannoma. First meningioma was removed, and in the second stage, schwannoma was removed, and this is the final image of a patient. So these are only curiosities. So what we do, what I think it's reasonable, it's straight or curved incision, it doesn't matter, laterally. Muscles should be moved more medially and as much as possible laterally, because the lateral slope gives the angle of approach as well as necessary drilling. It doesn't have any sense to drill more than the muscles allow you. C1 laminectomy or hemilaminectomy depends. Condyle resection only to reach the vertical line, or not even resection at all, because you see the hypoglossal canal from a medial aspect. Posterior fossa base drilling in larger tumors is necessary, and it's paramount. It should be flush with the skull base and as much lateral as needed. And if needed, then go upwards along the sigmoid sides. Never needed vertebral artery transposition. Always the VA entry is the limit of drilling, and it's usually not necessary at all, because the work can be done from above and below the condyle, and as well it can be done from posterior and anterior to the vertebral artery. So there are 2 problems: the jugular foramen. If the tumor reaches too laterally, it's a really dangerous area. And the other dangerous area is hypoglossal canal and the 12th nerve, because 12th nerve is the last you hit. That's most frequently the last structure which is covered by the tumor. So it's the last structure you see. So I call it enough-lateral because it's really individual as much as you need according to the tumor. There is almost always good plane against the stem. There were only 2 cases where the plane of dissection was not clean against the brainstem. Of course, there is some danger to 11s through to 12s, especially 12s. The lesser danger is in vessels and its perforators, not the large vessels, and nearly negligible danger in brainstem, and it's quite frequently from manipulation. There were 2 cases I have that. So it's very rewarding surgery, and it's very clean and nice surgery. Of course, it's a good topic for IANA, and everything I have learned about that was from Bernard George. This is in 2007, after the party during the European Skull-Base Congress. And I just would like to mention Bernard George and Fred Gentili, who both were good friends to all of us. Thank you.
Thanks, Vladimir. Fantastic as usual. And we'll leave the questions for the end. Sanjeev, are you there? We can maybe...
If we move it back to long listing, will that be fine?
Hello.
Yeah, Sanjeev,
Hi,
you
sorry.
want to start with the next...
Yes, no, I agree. Great talk, as always, Vladimir. But yeah, I agree, Ramesh. Let's go to the next talk.
Yeah. Okay. Prof. Luciano?
Yeah.
If you're ready, we can start the
Yes,
presentation.
I'm ready.
Yeah, you can share it.
I hope you can see my presentation.
Yes.
I would like to enlarge if possible.
Yeah.
Yeah. So hope you see the enlarged version. So my presentation today is the cerebellopontine angle meningiomas with and without ICA invasion. This is my disclosure, nothing special to disclose. Of course, very relevant is always the anatomy of CP angle, like we had the opportunity to hear before. Meningiomas are usually benign tumor, even if they have there are some atypical and anaplastic tumors, but not so common, especially anaplastic. So CP angle meningiomas account for 8 to 23% of all intracranial meningiomas, typically are benign and slow-growing tumors. And symptoms and signs sometimes appear only when the tumors are very large. Sometimes could mimic vestibular schwannoma, especially when they have an internal auditory canal invasion. The main treatment is possible, of course, is surgical, and we have 2 opportunities. The removal by the retrosigmoid approach and translabyrinthine approach. Translabyrinthine approach should be preferred only for small tumors without hearing, so with hearing loss. Allows a direct access to the tumor, especially if there is a ICA invasion with less cerebellar retraction. But the majority of cases, especially in big, larger tumors, we prefer to do the gross total removal by the retrosigmoid approach. I usually prefer this approach especially for large tumor. And the tumors when we have to spare the hearing, especially when there is not, of course, a hearing impairment before. There is no accordance in the literature in between the different articles regarding the frequency of this tumor. In this handbook of clinical neurosurgery, McDormand and colleagues reported that CP angle meningiomas represent about 50% of CP angle meningiomas, so PCF, posterior cranial fossa meningiomas. But if we take in account several articles of the literature with the biggest series reported by the big names, we note that in the SAMI series, we have 72 cases in 24 years. This Boston series, 40 cases in 11 years, so more or less 4 cases a year. And in this other series of North Carolina, of the Durham series, we have 34 cases in 80 years. Then in Rio de Janeiro, we had 24 cases in 28 years. So we see that except for China, that they have always big series, but we have more or less 4 or 5 cases a year, including this Turkish series published recently, in 7 years, 22 cases. And we have a series of gamma knife 74 cases in 20 years. And I say, why gamma knife? Just quoted this from Luis Borba, but it's coming from Cushing, of course. Nothing is more gratifying than a radical removal of meningioma without neurological symptoms after surgery. These are, of course, cases that I have excluded from our series because there are not CP angle meningiomas. There are some tentorial or craniocervical junction meningiomas. We removed it with different approaches. Of course, this again is a CP angle meningiomas, is a craniocervical junction meningiomas removed by the elite approach of Fukushima, 2 cases. So we selected 29 cases of CP angle meningiomas operated on in 8 years. Main majority of cases were female. In 7 cases, the touch of the tumor was in the inner petrosa. In 4 cases, the CP angle and inferior tentorium. And in 18 cases, we have CP angle meningiomas with ICA invasion. It's important to stress that in the same period, so we operated 29 CP angle meningiomas, but more than 200 vestibular schwannomas. So the frequency is very different in between these 2 kinds of tumor. In all cases, we performed a retrosigmoid approach, and the total or near total removal was accomplished in 26 cases and subtotal in 3. Only in 1 case, we note of this subtotal group, we noted a progression, and we treated this with the stereotactic radiosurgery. The Fukushima lateral position we use for all CP angle tumors, and this is the typical approach we use with 3 centimeters, more or less 3 centimeters squared retrosigmoid removal of bone craniotomy with exposure of sigmoid sinus and transverse sinus. And the opening of the dura we do with followed by decompression of CFS suction of the cerebellar lateral medullary system CSF aspiration for decompression of cerebellum and access the angle. This is a large tumor we operated last year, and is that the same? The position is always the same. This is the craniotomy we did, and considering that the tumor invaded also the convexity of the dura convexity, we just started directly with this laser thulium. You know, I use this for many tumors, especially acoustic and meningiomas, and this was very helpful because it is cutting and coagulating. And this is the bulking of the tumor that we performed with the CUSA and with the laser. This was the final. At the end, it was a little bit bleeding in the fundus of the tumor, but all the cranial nerves were respected by a bit with the arachnoid layer covering it. This was the last fragment of the tumor. It was a huge tumor that we removed completely, and the hemostasis what has been done with the Surgicel and with this Tacocil. At the end, this very large operative field was completely controlled. The bleeding was completely controlled, and the removal was, in the end, really total, without sequelae. She was neurologically intact, and the 2 days after, she was working on the department. This is another case of the smaller tumor, of course, resembling a vestibular schwannoma, with vertigo, tinnitus, and slight hearing loss. At the beginning, we were oriented for a vestibular schwannoma, but with the sequences of the surgery, number 1 was the craniotomy, standard craniotomy we do in all these cases. Number 2 is opening of the lateral cerebellary system. Like in this moment in the video you see, the opening is a fundamental step for suction of the CSF, decompression of the cerebellum, and everything is much easier after this step. Opening the dura, we prefer to open in the dura in a way to leave just small flap of dura over the cerebellum. Then we approach the CP angle system, and like you can see, number 3 picture, we exposed this meningioma, quite vascularized. This is the step, and coagulation of the surface and deafferentation of the dura of the basis of the inner petrosa. And I use, as told you before, the laser thulium, because it's cutting and coagulating at the same time with low penetration of the warming and low risk for the cranial nerves. Then I removed, using the arachnoid plane, the capsule, displays a little the capsule, and the next step was to search possible position of cranial nerves. So a little bit more of the compression with the sonopet. Then cutting the arachnoid, we found the plane, and this appeared not to be acoustic schwannoma, but it looks like meningioma. So this is the timing of a stimulation for confirming the position and the function of a fascial nerve. I use monopolar probe, sometimes bipolar, but I prefer the monopolar probe. When I close to the nerve, I use a very low intensity stimulation, 0.5, 0.2, 0.1, sometimes 0.05, when the nerve is very proximal. Then this capsule elevation, again, cutting with the laser thulium. Then the laser thulium is essential also for the coagulation of the dura over the internal auditory canal and the attachment of dura. So it's possible with the laser to do Simpson 1, Simpson 0 removal of the tumor. So a small amount of tumor inside the auditory canal was possible to remove without opening the canal itself, because it was coming easily. And at the end, we checked the function of fascial nerve, and we checked all the other nerves, and hemostasis was done. This was the post-op. The lady was walking the day after the surgery, and the hearing a little improved, and she was completely cured by this VH1 transitional meningioma. In all cases of CP angle, we assess a complete intraperitoneal monitoring, including the tube with the lower cranial nerves electrode, the trigeminal nerve, the 7 and 8 cranial nerves, and also these evocate potentials, brainstem evocate potential. So some of the sensory and motor potentials, of course, but the most important use are the blink reflex and potentials of the lower cranial nerves. And during the surgery, time to time, we repeat the stimulus just for understanding there is some changing in the function of the lower cranial nerves and the other nerves, facial nerves, and trigeminal nerve. Corticobulbar potentials are so essentials in the during the surgery for assessing possible damage, possible ongoing damage that we can reduce by use of papaverine or use of steroids on stopping a little the surgery around these cranial nerves and moving to another portion of the tumor. So this is the tube with the lower cranial nerve monitoring, using in any case of CP angle tumor. Special attention I would like to put to this CP angle meningiomas that had ICA invasion. Cohort is 18 patient, more or less the main age was around 50. The mean diameter was around 3 centimeters. And there is a subgroup of this tumor that have a little or a big jugular foramen involvement. It is around less than 20% of cases. This is a special subgroup in terms of results. The majority of symptoms, majority of cases, the symptoms were hearing loss, vertigo, headache, and trigeminal symptoms. Rarely we had dysphagia and hemifacial spasm. And this is a recent article published on Neurosurgical Review, just focused on this kind of tumor. In all cases, we performed a retrosigmoid craniotomy in Fukushima position, ultrasonic aspirator for the internal auditory canal opening. I use much more frequently than the drill, just because the discussion that before we had with Pablo. And because the presence of cottonoid is limiting the use of the drill, and the ultrasonic aspirator with bone tip can allow to leave all the cottonoid in place, and you can use the ultrasonic aspirator. I can open the canal more or less in the same timing, probably a little bit slower, but more or less you don't lose too much time for opening very well the internal auditory canal and exposing the tumor inside. Then thulium laser is essential for coagulation and debulking. We, in many cases, especially in last cases, we use endoscopy, rigid endoscopy for the control of the quote inside the canal and in the CP angle. Fluoration was very useful. We started to use since 2 years. We published a series of acoustic schwannomas, not yet of meningiomas, because especially CP angle meningiomas with fluoration were not too many. But anyway, we had a big collection of meningiomas that are very well evidenced by the fluorescein. And then the monitoring I told you before. The results change a lot in relation to the the point of starting of the tumor. Of course, petroclival origin is not included in this series, but if the tumor in origin from the premeatal or postmeatal, meatal area have different difficulties and different concerns. So the involvement of jugular foramen is very important, as I told you before. And the final stimulation of the facial nerve, the threshold was around 0.12. Gross total removal was in majority of cases, and near total in the remnants. So near total or gross total in all these patients with ICA invasion. In 9 cases, we could consider a Simpson grade 1, in 4 a Simpson grade 2, and in 5 a Simpson grade 3. Like in this left imaging, this was a grade 3 because it was not safe to remove this portion of tumor inside the canal. And this could be considered subtotal or near total. I consider it near total removal, but anyway, it's possible to discuss if this is really a near total or subtotal. I accept any comment, of course. Anyway, the majority of cases were benign tumors, and in 17% of cases, the tumor was of H2. The discussion highlights that our gross total removal of 72% is quite consistent with the conclusion that we can remove frequently, completely, and cure the patients with meningiomas of a CP angle invading the internal auditory canal. Excellent functional preservation, no permanent facial palsy. At 6-month follow-up, no one had facial palsy, including HB2. So majority, all patients had HB1. Majority since the beginning, and someone had a transient HB2, HB3 recovered in 6 months. The systematic use of ultrasonic aspiration for internal auditory canal is very useful, and multimodal monitoring is a key point. Endoscopic inspection of distal internal auditory canal is essential for confirming the total removal. And fact, the outcome are the jugular involvement, the sides, even if we had, as I showed with you, big tumors with no relevant problems after surgery, and possible adhesions to brainstem and cranial nerve. I go fast to present the results. At the 6-month follow-up, mortality was 0, normal neuroexam in 27, ipsilateral anacusia in 1 patient, a slight facial hypoesthesion in 1, and seems to be safe to remove this patient in these tumors independently to the age of patient if the AESA scale is careful considered. I mean, patient careful selected according to general condition, even if older than 65, could be treated safely with retrosigmoid removal of tumor, attempting in all cases the gross total removal. Complications, we had 4 cases of CSF leakage resolved without any neurosurgery, with not late consequences on the neurological point of view. We had 4 transient diplopia with for 6 cranial nerve, transient facial palsy I told you before, transient ataxia, and transient paresthesia of 5th cranial nerve, dysarthria and dysphagia. But we had only 1 case of permanent neurodeficit, what was hearing loss. So in conclusion, CP angle meningiomas are challenging tumors to remove safely. Adequate knowledge of bony, vascular, and nervous anatomy is necessary, of course. Retrosigmoid approach limits the complication rate and increases the possibility of gross total removal. Tumor size and extent of resection are important risk factors for the development of possible postoperative complications. No significant difference between older and younger patients in older patients if older patients are carefully selected. I can skip this. This was interesting, but it's probably too late. But it was a case where we confused CP angle meningiomas, but at the end, histology it was an inflammatory pseudotumor. And if you saw
in this video, we present
just fast the image and the clinical symptoms, it seems to be a CP angle meningiomas, lower CP angle, low CP angle meningiomas. But like especially in this image, it could be considered this, and we remove it as usual. And
tumor mass that appears.
Sorry. Anyway, I skip this, and I would like to invite you to this meeting. We will try with my friend Martin Samish and Laurie Radcliffe, the general manager of Fukushima. We try to organize this in March 2027. It's a post-Olympic neurosurgical winter meeting, reappraisal of the Fukushima winter meetings we did before or after any Winter Olympic meeting, and we will try to arrange it in Cortina next year. You know that is already finished in 2 or 3 days ago, the Olympic meetings in Cortina, and it is a work in progress. We don't know for the moment exactly the date, but please fix the end of March probably is our tempting dates, and we will come soon with the correct date as soon as we know. Thank you so much for your attention.
Thank you, Luciano. Thanks very much. And Sanjeeva, you want to bring in our next speaker?
Yeah, Luciano, thank you. Great talk as always, and sounds like a great meeting. It's a real pleasure to now invite Professor Miguel Ares from Malaga. I'm sure you all know very well, with a huge experience in both open and endoscopic chordoma surgery. So we're looking forward to your talk. Thank you for joining us.
Miguel?
I think you're muted, Miguel.
Okay.
Can you... Oh, okay, yeah.
I hope you can see my presentation.
Yes. Yes.
Okay. So, good afternoon, everybody. Thank you for inviting me to participate in this wonderful meeting. Ramesh, a special congratulations for your new, let's say, appointment. And well, I will start my presentation of microsurgery and endoscopy in clival chordoma. Al-Mefti like to say all roads are leading to the clivus, and we will focus on extradural lesion of the clivus, and we have to mention that during the 70s, 80s, and 90s, transcranial, transsphenoidal, and transfacial approaches were used to deal with this lesion. This is a tumor. All our personal
sorry,
cases.
1 second, Miguel.
Sorry?
1 second, Miguel. Is that slide moving? I can't see it moving. I don't know for others.
Okay.
Yeah, if we could restart and then... Yeah, if you could...
I don't know what's going on.
No, if you just go back to the full screen now and then yeah. Not that one. Yeah, there. Try that. Well, what does it say? Keynote. Try again. Is it moving? Not
you can
moving
see,
for us.
You can see that?
And you, Miguel, try to, when you click share, stop sharing and share again. Just share your desktop.
Okay, could be this is the problem.
Thanks, Pablo. I think I couldn't really read what was on the screen.
Toda la pantalla. No, something is wrong.
Yeah, we can see the second slide, I think.
Now it's working, Miguel.
It's working.
Yes.
Thank you for this note, my dear Pablo. So, well, this is
here.
the second. Thank you so much. This is the second slide. All roads are leading to the Clivus, but we will focus on the roads leading to the extradural Clivus. Cordoma is the star for that. 70s, 80s, 90s, transcranial, transsphenoidal, and transfacial approaches. This is one case operated on by means of microsurgery in 1993, right after finishing my training program. All are personal cases. At that time, we used to take advantage of the so-called extended subfrontal approach, as you can see here, by frontal craniotomy, cranioorbital craniotomy, and this is the decompression of the optic nerves and removal, fortunately, removal of the intradural at the posterior fossa area of the tumor by means of drilling the clivus, obviously due to the soft consistency of the tumor. This is the postoperative MRI, pretty satisfactory reconstruction with a very well known pericranial graft. This is the open door maxillotomy as popularized by Professor Crocker, just a microsurgical approach, Crocker retractor, very useful for many lesions. You can see here this lesion just outside and inside the intradural space and removed by means of this microsurgical approach, as you can see here. Okay, and after that, this is the view of the intradural space at the posterior fossa, then reconstruction with autologous fat graft, spinal drainage, and so. Then endoscopy came, and endoscopy came to stay. This is a very similar case to the one we saw at the very beginning. But in cases like that, nowadays, we can do endoscopy to remove that through the nose. You can see the reconstruction with autologous fat and also the well-known nasoseptal flap. But when everything seems to be about to be solved by endoscopy, cases like this one are coming to our clinic. This is a patient that couldn't just be at the recumbent position due to difficulty to breathe. Just coming from another institution, you can see this not very much satisfactory craniospinal fixation. So for cases like that, distraction of the C2 vertebra, you can take advantage of the classical open and microsurgical approaches. This is the high anterior cervical retropharyngeal approach done in conjunction with ENT, an initial step making an anterior removal, and in a second step, as you can imagine, removing this non-satisfactory procedure for fixation using, this more modern system. We had removed the anterior half of C2 in the initial approach almost completely, so remaining a small part of the odontoid process. And in the second one, we removed the arc of the C2. So everything was relying on these rods. And after a certain period, one of the rods were broken, as you can see here, but we stand with some external thesis until some spontaneous fixation after having put some autologous bone came. But later on, the patient presented another recurrency. What you can see bottom left is not, let's say, the tumor, is reconstruction with autologous iliac crest, and also using furillary cadaveric furillary rods, just trying to increase the instability, as you can see here. And then another recurrency, as you can see over here. And you can see at the right side the displacement of the vertebral artery. So by means of an open approach, we managed to remove this new recurrency. So for certain cases, we can take advantage of endoscopy and microsurgery. This is a typical chordoma case, not high quality of the preoperative MRI, I'm sorry, but you can see how the lesion is involving the upper, middle, and lower third, that is to say, involving the CVJ aspect. And as you can see, bottom left, you can see this aspect of the posterior, inferior, and lateral component of the chordoma that, at least in our hands, are not very well controlled from anterior endoscopic approach. So this is the postoperative MRI endoscopic approach, good just to remove the upper and middle third. But if you look at the lower third, you can see some remaining tumor, and in the middle and bottom right, you can see remaining tumor due to this, as I mentioned before, inferior, lateral, and posterior aspect, sometimes intradural aspect of the tumor. So for cases like that, we just plan a transcondylar approach. This is the right side. This is the V3 segment of the vertebral artery exposed and protected, drilling of the bone, and this is a real condylectomy, partially involved by the tumor, and this is the way from this lateral aspect you can get the anterior anatomy of the CVJ, and even removing, of course, odontoid lesion and retropharyngeal tumor. After that, unilateral occipito cervical fixation that nowadays are abandoned because of some problems. If you send the patient to proton beam therapy and metallic hardware are not getting along very well. In any way, this is the fixation we use in this kit. We have to remove that. This is another example, Hugh chordoma, nice removal of the upper and middle third. But if you see the lower left, bottom left, you can see this inferior, lateral, and even posterior component of the tumor. So this is after the first approach by means of endoscopy for upper and middle, and in a complementary transcondylar approach, we try to completely remove the CVJ component. This is in this case with fixation to the second cervical vertebrae. And for certain cases, we just go to microsurgery directly. And this is our policy for chordoma involving the lower third, that is to say, CVJ aspect of the craniovertebral anatomy. This is one of the typical tumor. Sorry, you can see the involvement of the CVJ, some part intradural, some part extradural. You can see the CT scan with the involvement of the condyle and lateral mass of C1, mainly at the left side. And this is intraoperative view by means of the transcondylar approach. You can go, of course, intradural. You can go, of course, extradural. And this is the way you can, if you see bottom right, you can see the the accessory spinal nerve after intradural removal, and you can see extradural and dural component of the tumor removed, and the B4 segment of the vertebral artery, 360 degrees release of tumor. This is the postoperative MRI, pretty satisfactory. And this is the last example. This is another case, a young patient, 18 years old, with a slight headache, MRI showing this complex tumor that is mainly at the lower aspect, involving intra and extradurally the CBJ aspect. You can see that. If we look at the bottom right picture, you can see the complexity because the lesion is going intra and extradurally, ventrally, just right behind the pharyngeal space. So we plan this far lateral approach. We did a bilateral far lateral approach due to the bilateral extension of the lesion. This is the tumor. We are on the right side. Not easy tumor. You can see the fibrous consistency. Ultrasonic aspirator was not enough. We have to remove that, just pulling, coagulating, cutting. Not easy case. This is the moment of identify and just releasing from tumor the vertebral artery about to be seen. This is the partial destruction of the second vertebrae joints due to the tumor. We try to keep in as much as possible in order to avoid postoperative instability. Okay. Just going forward, we are just working anterior to the medullary region, extradurally. Okay. And then this is how we can get, this is the region of the odontoid process and retropharyngeal space able to be accessed by means of this approach. And then intradural opening, this is the medullary region. And we can see this bulging tumor right anterior to the medullary aspect, removed by means of microsurgical techniques. And this is okay. Again, doing that, not easy, bleeding, very bad cleavage plane. And this is the final view. And due to the big opening at the anterior dura of the CBJ junction, we just use this big piece of muscle and fascia trying to restore the anterior dural plane. Well, this is the postoperative MRI. Unfortunately, the resection was not complete due to this difficulty to identify the tumor in any way, decompression of the brainstem, some areas, high signal areas of remaining tumor. We hope from now on the situation of inadvertently leaving tumor back is going to be improved because we just started months ago with this intraoperative MRI operating room that for sure is going to improve our results. This is the last example. This is apparently an invasive pituitary adenoma operated on months ago. We saw some difficulty to carry out the removal because of the fibrous and bleeding situation of the tumor. We did the subtotal removal, radiotherapy, and then this huge recurrency. You can see the indentation of the mesencephalon and pontine region. For this case, we plan a COC craniotomy, and this is the postoperative MRI, very unsatisfactory due to profuse bleeding, brain infarction, and unfortunately death of the patient. But in any way, I think the idea of the frontotemporal craniotomy with the addition of the cranio-orbital zygomatic osteotomy was very good as microsurgical approach for this case. Well, just summarizing, we can see here Charlie Chaplin fighting. This is not an issue of fighting. This is something that very frequently we see in major meetings, people in favor of endoscopy, people in favor of microsurgery. I think that, of course, revolutionary approach came from endoscopy, who came to stay. Endoscopy and microsurgery must be complementary. And I think that the clavicle chordoma is a very good example. In our understanding, upper and middle third can be better approached by means of endoscopy, but for lower third and occipital C1 and C2 involvement, microsurgery, far lateral, transcondylar approach are honestly pretty good. The last consideration is in regard to the need of learning microsurgery and endoscopy. The junior colleagues have to learn the classical open skull-based approaches, and I think the senior neurosurgeon has to be more and more involved in endoscopy as a very important tool for that kind of lesion. Thank you very much, and I very much appreciate being with all of you. I like to salute and send greetings from Spain to the previous chairman, Pablo, and of course, our father for this wonderful initiative, Vladimir Benes, and my brother, Imad Kanan. Thank you very much.
Thank you.
Thank you, Miguel. Thank you for an excellent talk as always. I think it's time for the discussion, and we can have a look and see if there's any questions as well. I can't see Ike here, but Professor
Landero is here.
Professor Landero.
Yeah,
yes, you
so
are.
we start from the
Hello,
first
Jose.
thing. Yeah, we can start from the first speaker, Vladimir's talk on meningioma.
I have a question to Professor, our friend from Czech Republic, Benes, Vladimir Benes, is here?
Yes.
Here. Oh, sure. And Professor Vladimir, I wrote a paper 2 years ago, published in the Surgical Neurology, about the new classification to the old Cushing classification to foramen magnum meningiomas. And I emphasize the use of the subtonsillar approach, even to anterior foramen magnum meningioma. But the first condition for to do this approach, midline subtonsillar approach, is the tumor is below the bulbopontinal sulcus. If you have the tumor below the bulbopontinal sulcus, you don't need to go so far to find the vertebral artery closer to the C1 transverse process. And then you gain time for dissect the tumor without any problem. But I'm still using the far lateral approach, but there are some nuances for choose this approach. Why don't you use a midline approach, subtonsillar approach for foramen magnum meningiomas placed anteriorly?
I fully actually agree with you. I was considering using midline approach because there is so much space as long as the tumor is low enough, exactly as you say. But this is a the enough lateral approach is my policy. I like it, and it doesn't give you any extra work or extra complications. So I like to come a little from the oblique line. And considering the classification, I certainly know the work, but Bernard Jor was such a dear friend to mine that I still use this classification.
Thank you.
Thank you very much, Vladimir. If any other further discussion about Farman Magnum CV junction meningiomas, if not, then we'll go on to Prof. Luciano's talk on the CP angle meningiomas. I may ask Prof. Luciano Astronadi that this you're very fond of this thulium laser. I see that you use it for all these sort of cases. I haven't seen it. I don't know which other specialty uses it. If some other specialties like liver surgeons using it, I also might borrow it from my theater. Otherwise, I have to buy one. What do you think? Is there another specialty using it?
Yes, I'm sure. I'm sure there are several specialties they use, especially urologists. Urology, they use a lot. The same machine, but much more stronger than the one we have. So the amperage, I mean, the power that we use is very, very low in comparison to other specialties. General surgeons, they used to. I motivated this from the urology. And I saw the machine. I tried some cadavers and some other, tissues. And I understood that it's very useful not only for cutting, but also for ultra micro coagulation. It's very, very useful and safe. Especially this, I started with a CO2 laser, but was not so safe like this because it was too strong and I didn't like too much. This is very, very useful. You have it stop, of course, and the power is not so strong, and the coagulation in comparison to the bipolar is 10,000 less. I mean, bipolar is a millimetric diffusion of worm, and laser is micrometric diffusion of worm. So it's very safe in comparison to bipolar. This is my personal experience on probably now more than 300 cases of tumor treated by laser.
I have a comment on this one, Luciano. Oh, sorry. About the time consumption with the laser. Does it take longer time or not? I remember this from CO2 laser, taking meningioma layer by layer with penetration of 1 millimeter, wetting
Right.
everything around it. And by the time once we have the CUSA, we abandon the laser at large.
Right.
Please give me your opinion.
Very correct. Very correct, especially with the CO2 laser starting from the microscope at the beginning, it was very, very low, very, very slow. Now with the handheld lasers, especially this thulium, the timing is probably sometimes a little bit longer at the beginning of the learning curve. But when you understand how to use it, it's very, very, if you have a soft tumor, as I had yesterday, the sonopet is very much faster, of course. It's faster and safe too. But if you have in some portions of the tumor, the capsule, and not only the capsule, a hard tumor, this cutting and coagulating at the same time, it's very useful. You can manage also the power from very, very low, as I use in some acoustic schwannomas close to some nervous or brainstem, to very high, to much higher, of course, power when you have hard meningiomas in the convexity or in very safe area. So in this, when you have a correct learning curve, you find it very useful in many tumors. This is my experience, of course.
Thank you very much. Professor Lantero, any comments about Luciano's talk? Okay. I think we'll have the Prof. Miguel Larraz talk on chordomas. Very challenging cases you'd sort of shown here. I think it is commendable, and thank you for showing those cases. And Prof. Schroeder, you want to come in? No? We can't hear.
Unmute your micro, Henry.
Henry, unmute yourself.
Sorry. Miguel, thank you for this presentation, but I don't agree that we cannot use or we should not use for the lower clivus the endoscope. I think it depends. When the tumor goes far lateral, then it's a little bit difficult. But even if it goes down to C1, C2, we can do it nicely with an endoscope from the nose. And you have shown us nicely when the tumor is in front of the brainstem, you have a small window, you go in between the nerves, it's difficult for you. From the front, you see everything, you can dissect much better. So what we do in these cases, we make an endoscopic endonasal approach first, and when we have to resect C1, C2, then we come anyhow from the back to make the fixation. And when you have lateral tumor parts, you can get them from this approach from the back. So I would strongly recommend that we use the endoscope also for the lower clivus.
Okay, thank you. Well, I have been using that, but honestly, in my case, with disappointing results, because I think it's not easy to manage from the, let's say, resection point of view, the tumor when the tumor is around vertebral artery, around the nerves, and right behind the nerves, and just lateral and inferior. So in cases like that, I do prefer transcondylary approach. This is my understanding. I don't think it's easy to remove that inferior, posterior, and lateral, sometimes bilateral aspect of the tumor by means of endoscopy. And on top of that, in terms of radicality, in as much as possible. But this is I put in one of my slides, this is my point of view. It is not the universal truth. This is my reflection after many years of practice with Cordoma. I'm sure you are able to do that by means of endoscopy. But the I love endoscopy, but the resection of the tumor, whatever the tumor is, the management of the tissues, the dissection from delicate areas is much better with microsurgery than with endoscopy, by far, in my opinion. So lower third, lateral and posterior aspect, intradural growing of the tumor, to me, transcondylar approach is a wonderful example. And by the way, I do concur with Dr. Landeiro in regard to lesions that are in the, let's say, according to the Cushing classification. I think we all are doing the same. Just for the Cushing classification, those mainly below to the foramen magnum level, just transfacetal approach, just drilling a little lateral C1 is good enough without transcondylar or paracondylar approach.
Yeah, what I think the problem is when you have not a plane, what you showed in the recurrent case. I have a similar case, but I had to abandon the procedure because there was no plane. When you have an arachnoid plane, you can dissect very nicely under the endoscope in the front. That's no question. You have manual dissection, it's no problem. And I don't agree with your terminology. You see microsurgery. So what I think, for me, we do microsurgery under the endoscope. So there's an endoscopic microsurgery, and you can use a microscope. This is microscopic microsurgery, but the dissection is exactly the same. Traction, counter traction, sharp dissection. So for this point, I don't agree with you. I think both is microsurgery.
I do accept for the next time I will use with endoscopy and without endoscopy.
Exactly.
It will solve everything. But I do concur. Henry, I do love endoscopy, believe me. I do a lot of cases, I do love endoscopy. But
thank you.
I have some preferences.
Imad?
I have to go in between. The purpose going through the nose, I have done a couple of them, of course, especially they are the midline, not involving displacing brainstem. It's a marvelous endoscopic surgery. You have nothing in front of you and you have a barrier behind the tumor. If they brace vessels and going on the side. Even that part, you do it as a first stage. You decompress the brainstem, the central part of the brainstem, it relieves the arachnoid membrane at the back when you are doing the resection laterally. If you complement it with your approach will be easier after the first stage decompression through the nose because the space is there, brainstem is relaxed, you don't deal with the pressure on the brainstem and compression, and arachnoid opened up. It makes the dissection of the lateral component easier. So, in two-stage procedure, but the first will be a decompression from the front. I've done it a couple of times and it works nicely. You don't have a filled posterior fossa completely. You have decompressed part of it.
Thanks very much, Imad.
A comment. I agree with Imad if you plan from the beginning a staged operation, because in front you can easily decompress the brainstem. But at least in my experience, the chordoma usually is soft, so is suckable. But if the aim is the total removal, including part up to or part of a normal bone, then for the bone, I prefer the anterolateral approach like Bernard George or the far lateral, even because through the far lateral route, at the end, in order to reach the upper part or decompress the brainstem, I always use the endoscope. But to remove as much bone as possible, for me, I use, of course, endoscopy, but the simple midline approach, for me at least, is hard to stay on the lateral part. But the combination with the endoscope and microsurgery for lateral approach maybe is one of my favorite.
Yeah. Thank you.
The main problem with chordoma is still the CSF leakage rate. When you make this, you go down. Then this is my major concern with the leakage that we have. And you do lumbar drain and another revision and sometimes two revisions. That is the problem when you come with an endoscope endonasally and you resect all the clivus. You can do it. I have a 45-degree endoscope and I have the curved drill where you go far laterally and you can drill a lot, which is not in the midline. Also, you can reach tumor, which is far lateral. This is possible. But the CSF leakage, that is still a mess.
It's a problem, yes.
Yeah. Okay, so many ways to skin a cat, right?
Anything else, Akiva, finally, before we close?
Congrats for everybody.
Yeah. No, I think Prof. Giovanni has raised hand. You want to comment something, Giovanni? Can you unmute? No, can't hear anything.
I start again. I have no microphone. Compliments to all the speakers for this presentation of this IANA section. Very interesting, and compliments to all of overview. But I understand that all of you have some complications. So may I remember you that in June will be the Kekiturel meeting on complication will be run in Italy, and I sent to you the flyer. So welcome if any of you or your collaborator will bring one case to discuss. Thank you.
Thank you. Thanks very much.
Great. Well, I think that was a great meeting. So well done, Ramesh, on your first one.
Thank you. I think it's great participation, and hopefully they'll be there. We can see Pablito as well online. So finally, thanks very much, and thank you, Victor, as well, Antico. So see you all for the next one.
Ciao. Bye-bye.
Bye.
Ramesh, take a picture, Ramesh.
I have already taken a picture. Well, maybe do one more.
Pablito.
Pablito.
Okay. Bye-bye.
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 Bye.